Hi, I'm Dr. Benjamin Cohen. I'm the co-section head for inflammatory bowel disease at the Cleveland Clinic. What is ulcerative colitis? Well, ulcerative colitis is an inflammatory condition of the bowel that typically affects the superficial mucosal layers as opposed to Crohn's disease, which is a transmural disease that affects all the layers of the bowel wall. Ulcerative colitis is a chronic condition that can go through periods of disease activity as well as remission. And it's important to monitor and treat ulcerative colitis, as this is the best way to maintain remission and prevent severe flares, which could necessitate hospitalization or even surgery. What are some symptoms of a first time flare up? So, some of the symptoms that you might experience in a flare up for the first time are diarrhea, rectal bleeding, urgency, sometimes cramping associated with bowel movements. Interestingly, pain is not a typical symptom of ulcerative colitis. When patients have more chronic pain, that may indicate that something else is going on. Every patient is unique, and what may affect one patient may not impact another. It's also important to note that not all symptoms indicate inflammation. So many patients can have overlapping irritable bowel syndrome that may be contributing to symptoms that are similar to what you would experience with ulcerative colitis, but not actually due to active inflammation. How is ulcerative colitis treated? Because it's a chronic inflammatory condition, we often need to use maintenance medications to keep disease under control and prevent disease flares. When patients present acutely with symptoms, that's a scenario where we may be able to use corticosteroids to quickly decrease inflammation and control symptoms. However, these medications shouldn't be used as a maintenance medication or for prolonged periods because they have many different side effects to the patient, including increased risk of infections, bone loss, weight gain, among other things. In patients with milder disease, this is a scenario where we can use medications that are not systemically immune suppressing, called 5-aminosalicylates, and these can work by direct contact on the inflamed colon when they're administered either orally or rectally, and these are very safe medications. When patients have moderate to severe disease or they haven't responded to conventional therapies like 5-aminosalicylates, this is where we use advanced immunosuppressive medications such as biologic drugs or oral small molecule therapies. And these drugs work to more systemically suppress the immune system by various pathways to control the inflammation of ulcerative colitis. We have many different options at our disposal now, so it's important to have a conversation with your doctor to understand which of these drugs may be best for you. What type of surgery is needed for ulcerative colitis? While we have many more effective drugs to treat ulcerative colitis, still approximately 10% of patients will need surgery by 10 years after their diagnosis. The traditional surgery for ulcerative colitis is what we call a total proctocolectomy. So that's when the entire colon is removed. Now, patients may have two options at that point. One option is to have the total colon removed and have an endoileostomy. And then the more modern surgery is to have what's called the ileal pouch anal anastomosis, where a piece of the small intestine is brought down and attached to the anus. It functions as a final reservoir like your rectum so that stool can pass normally through the anus. Many patients prefer the ileal pouch anal anastomosis because you go to the bathroom the same way you would when you have a colon sitting on the toilet, as opposed to emptying your stool through a bag. An endoileostomy is a very good option for patients who don't want to worry about future complications related to inflammation in the J pouch or developing cancerous changes in the rectal tissue that's left behind. Oftentimes, if you have an endoileostomy, there's no further requirement for medication or other surgical complications. What is recovery from ulcerative colitis surgery like? For the ileal pouch anal anastomosis, it's usually done as 2 to 3 surgeries over 6 to 12 months. And I tell patients that the expectations for function after an ileal pouch anal anastomosis are to have on average 5 to 8 bowel movements per day, including 1 stool at night. Initially, after the surgery, the frequency may be a little bit more, but over time you should adapt and hit that range. Though, again, every patient is different and may have different experiences in terms of their symptoms, and it's important to talk with your doctor when you do experience a change in the type of symptoms you're having. With the endoileostomy, function with an endoileostomy is quite good. The stoma should be emptied on average, I would say, 4 to 8 times per day, sort of depending on the individual patient. When should you seek treatment? Well, if you're experiencing a change in bowel movements, I think it's always important to speak with a healthcare provider to make sure that further investigation isn't needed. The primary warning signs symptoms that I would worry about are when patients are having rectal bleeding, significant weight loss, waking up at night with bowel movements, or having incontinence or loss of control of bowel movements. Those are things that typically indicate that something more is going on than just irritable bowel syndrome or an intolerance to a food, for example. So definitely in those cases, I would want to get seen by a gastroenterologist as soon as possible.